Ara Deukmedjian, CEO and founder of the Deuk Spine Institute, and we are going to be broadcasting live spine surgery today. It is the 7th day of July 2020. Our country has been ravaged by the COVID-19 virus for the last 3 or 4 months, and it has certainly affected many businesses, including ours. Fortunately, we've had no cases of COVID-19 in our surgery center, and it's a safe place for patients to come and get their backs and necks fixed with surgery. The Deuk Spine Institute specializes in several things: curing neck pain, curing back pain, treating and curing radiculopathy and myelopathy. That's pinched nerves, things like sciatica, numbness, tingling, weakness. Our patient today, for this case, is a patient who's had a fusion in his back and now has developed what's called adjacent segment disease, which is a problem with the joint or disc above the fusion, which is causing him pain in his back and symptoms down his legs. So we're going to be doing the Deuk Laser Disc Repair, endoscopic repair of that adjacent disease, that's adjacent disc that's been damaged and herniated. And we're going to get the pressure off the nerves and treat his back pain. Good morning. It's Dr. Deukmedjian. I'm here. We're going to get started. You'll be awake for the first 10 minutes or so until we get everything set. I'll need your help, okay? So 2 things. Number 1, don't move your body. If you feel any pain or discomfort, just say ouch. And I'll give you some more medicine, okay? Second of all, if you do feel pain, we're going to ask you, is it in your back or is it down your leg? Okay, so you just got to tell us back or leg. All right, so I'm going to get started by giving you some numbing medicine first, okay? You're going to feel a little stick and burn. Now, he's had this prior fusion, and I want to know where we're going to get started. So I'm going to take a quick fluoro shot, and we're going to see where we are. All right, so it's a little bit higher than I want to be. Shot. That looks pretty good right about there. So let me have a marking pen. You don't? All right, so we're good. We're good. You're gonna feel a little stick and burn, okay? All right. You'll feel it on both sides. I'm gonna start with your left side. I apologize. Are you doing okay otherwise? Are you comfortable, sir? Yeah. Right? Sorry about that. And the other side. Unfortunately, there's no way around that one. All right. Yeah, I apologize. Doctor, are you trying to make him comfortable?
Oh, yeah. That's my mission.
Well, he seems to be feeling everything more than I would want him to be.
I think timing is everything, so I'm giving it to him. I have to gauge how much more he needs.
Sure. How's our blood pressure?
138.
All right, what can you do to get that down?
I'm working on it as it's
All right. So just because you've been coming here now a few times, when I come and do the timeout, you know you've got about 5 minutes till I'm in here doing all this stuff. So start working on getting the blood pressure down.
I've been working on it for the past 30 minutes.
How many minutes?
For the past 30 minutes, I've been giving like fire goes up like a dog.
I'm not cleaning the paint well.
What's that?
I'm not seeming to want to protect the paint well.
Did you understand what he said?
What did you say, sir?
Apparently I'm not wanting to participate well.
No, you're doing fine. This is,
It's a process.
everybody has their job to do, and hopefully we can get your blood pressure under better control. If you're having trouble I would recommend talking to Dr. Santiago. Have you talked to him before? He did a year of these surgeries with me, hundreds of them.
What trouble are you talking about?
With the blood pressure. He was always at 100.
I'm getting the pressure down with drugs, and the drugs take time to work.
All right.
Dr. Santiago is not going to tell me any drug I don't know.
What's that?
Dr. Santiago is not going to teach me any drugs that I don't know. I don't have everything I have now. I don't have everything. You know, there are drugs that can do it faster. You don't have it.
Yes. Yeah, but these drugs are the same ones we use all the time. And it may not be a drug that you don't know, it may be the technique you're using. Does that make sense? So he,
I'm using the drugs we have here.
huh?
I am using the drugs we have here.
Right, and I'm saying it may not be a drug issue. You may have the right drug, but it's a technique. It's how you deliver it, when you deliver it. That's what I'm saying. He may be able to help you with. Does that make sense?
I don't need help, sir. Okay? Just let me go to this patient. You started at
Yeah.
156.
Sure.
It's on 130.
Yeah.
Can't drop it.
Let me make it perfectly clear. This is 1,100 of these surgeries I've done. And every time I walk into the OR with Santiago, the blood pressure is already at 100 to 110.
Well, get Dr. Santiago.
So right now I have to stop and I have to wait.
All right.
So this is delaying our case. So I'm not used to delays. I don't want delays. So that's why we're having this conversation. I'm not going to back down because you're doing something wrong and you're offended, okay?
I'm not offended.
You are offended. You are offended. And that's why you're reacting the way you're reacting. I'm just telling you.
What I'm doing.
Well, I understand.
It's time to get the pressure down. It's
And I'm explaining to you what I've done hundreds and hundreds of times for these exact cases. And that is, when I scrub, that's about 5 minutes before I'm ready to get started. Otherwise, we have to sit here and wait. Are you awake?
Yes, sir.
All right. Are you uncomfortable? Shot. All right. Let's go lateral. Where are we at with blood pressure?
130.
That's it right there? All right. Shot? Why am I not seeing more posterior? Huh? Yeah, table down a little bit. All right, so for those of you watching, we don't edit our videos. These are live stream. And I'm very comfortable providing you with a live stream, though, so you get to see what happens in the operating room in real time without anything being doctored, so to speak. That's really what the experience is about. We could take these and edit them and get rid of the ugliness or the kind of things that make people concerned, but then it wouldn't be reality TV, would it? So we want the real experience in real time. Also, that gives you an opportunity to ask questions. So, are you comfortable, sir? All right. Shot? Now, what can you do to line that end plate up a little bit better, if anything? Shot? I don't know that those pedicles are lined up better. Shot? I think that's better. Luis, what do you think? Yeah. All right. Shot? Oh, we're close. Where do you feel that? Shot? Where do you feel that? Huh? In your back. All right. Just try to lay still, okay? I know it's a little bit uncomfortable. Shot. All right. Shot. It's not bad. We're right there. Very close to where we need to be. But just lay still. Shot. All right. Shot. I need to see back more. Shot. Shot. That's better. Try not to. Shot. I'm sorry it's uncomfortable for you, Shot, but we're almost done. Give me an AP, please. So you can see we're about to enter the foramen, or we're just entering the foramen. For those of you who see this screw down at the bottom of the screen, that is a screw. It's called the pedicle screw. That was placed during his original fusion surgery. It's looking good. Go back to a lateral. I need you to work on getting me a good, real lateral view through the disc. So for those of you in that view right now, Sean, are you showing the AP view on the x-ray that we just took?
Yes, we can see that.
All right, good. So you can see there are screws going into the bone, and now we're doing a side view. You can see the screws going into the bone. Those screws are in the pedicle of L3. So this patient had an L3-4, L4-5 fusion. I don't think I did it. Who did your fusion? Huh? Me? Oh, I guess I did. How long ago did we do your fusion? 2008. So that's like 12 years ago. Just lay still, okay? All right, I need a better view of that disc space. You're too far in the south. You need to center that disc space. Come on, Jordan. I shouldn't have to tell you these things, okay? I got other things to worry about besides telling you what to do. That's too far north. I would bring your fluoro back up. So our patient had a fusion 12 years ago and, you know, did pretty well, I presume, for a while. When did you start getting back pain again? We got to do better. So about a year ago, he started getting back pain is what he's saying. Yes, the patient is awake so far during the procedure. We are going to put him to sleep in a little bit. But he said he started, that's perfect right there. He started getting back pain about a year ago. So he was doing good. I guess he got, about 10 years out of the fusion. And then he developed something called adjacent segment disease. Shot. All right, that's it right there. And adjacent segment disease is something that happens with spinal fusions where the disc above or below the fusion will start to go bad. Shot. And in his case, it's the discs above. All right, in your legs. Mostly weakness in his legs is the symptom he had. That's why he came back to me. Yeah, just try to relax right now. This is where I need to focus a little bit more on what I'm doing. Let's go AP. It's amazing because he's got nice big foramen. However, he's got herniations into the foramen from his disc. And those herniations, that's good. We're a little bit higher than I want to be, but let's see if we can make this work. Go back to a lateral, please. You feeling anything? How's our blood pressure?
It's 130. You went down to 120 and bouncing back.
All right, see if we can keep it down. So I feel the herniation here, and I feel like we're just a little bit higher than I want to be. So I may have to redirect, but we're awfully close. Shot. And I hate to have to restart when we're this close, but I think I'm going to have to, because there's no way it's going to go. We're just against that end plate. We're so close. I think our fluoro shot is perfect. I'm really happy with that. Where do you feel that, Sean? Where do you feel that? In your back, Sean. Oh, we got it. Right? Where do you feel that? In your back or down your leg? What? I'm sorry. The anesthesiologist should be helping me a little bit right now, telling me what you're saying. What is he saying?
He's saying you're feeling it where you are, where you
In the back. Okay. All I want to know is if it's down your leg or not, or if it's in your back. And it sounds like it's just back. Lay still for me, sir. You're doing great. We've got half of it done, and we got to do the other half, and then we'll put you to sleep, okay? Just lay still. Lay still. What's your hand? You may feel that little burning again, but that's just me putting numbing medicine, okay? You're going to be fine. You just relax. That's going to help me. We've injected a total local of about 12 cc's. Okay? Dr. Confidence, did you hear me?
12 cc's.
Yeah. Just acknowledge when I say something. That way I know you've heard me. All right. So our patient has bilateral leg weakness, both sides. Bilateral just means both sides. And, you know, what I'm trying to do here is treat both sides with one surgery. So that means I have to go on both sides. When it comes to the lower back, if you're having bilateral lumbar radiculopathy, what does radiculopathy mean? Radiculopathy means a dysfunction of the nerve roots. And there's nerve roots in your neck, there's nerve roots in your lower back, and there's even nerve roots in the thoracic spine. The nerve roots in the thoracic spine rarely get compromised. You rarely get thoracic radiculopathy, but it is possible. It's just not common. Most people have radiculopathy affecting the cervical spine, which is their neck, or their lumbar spine, which is the lower back. And radiculopathy manifests itself as pain down the arm, down the leg, numbness, shot. So let's get an AP. Numbness in your hand, arm, if it's in your neck that you have the radiculopathy, We call radiculopathy in the neck cervical radiculopathy because it's a cervical spine that's involved. So cervical radiculopathy will manifest itself as numbness in the upper extremity, lateral. Tingling. Cervical radiculopathy can be present as tingling in the hand or arm or fingers, tingling like pins and needles. Weakness in the upper extremity. Okay, that's the facet. Shot. I can feel that I'm on the facet. I need to be a little bit higher. Shot. That's too high. You okay? The good news is we're almost done, Sean. So we're going to put you to sleep soon. Oh, you're not going anywhere? All right. Well, as long as you're comfortable, we're going to be able to be done very soon, Sean. And when you wake up, we'll be done. Shot. All right. So radiculopathy manifests itself as weakness, numbness, tingling, or pain. Those 4 symptoms. And it's either in the arm if it's involving your neck, or if it's involving your lower back, it's in your leg. Shot. And our patient here has weakness in his legs, and that comes from pinched nerves, from herniated disc above his fusion. Shot. Where are we at? That's really nice. We're just about there. You must have a rotational component. Slightly rotated. Shot. Where do you feel that?
Directly where you're at.
All right.
Slight radiation around wherever your phone's at.
Sorry about that. Shot. So the disc above his fusion is highly collapsed. Shot. That should be in. Let's get an AP. It's collapsed. You okay?
Oh yeah.
Let's see where we are.
We'll wake up all along.
Yeah. Your disc is 80% collapsed above your fusion. And I need to see your side. There, Jordan. All right. You see the needle in the disc space there, Luis? Huh? I do too. Just want to confirm. That looks perfect. You're lucky. That was a tough one, but I think we got where we need to be. So, his primary complaint, do you ever get back pain?
Rarely.
Okay. So back pain, we're not doing this surgery because he has back pain from that disc above his fusion that's now damaged. And there are many names, by the way, for that. We call it degenerative disc disease. We call it spondylosis. We call it herniation. But an injury to the disc always starts with an annular tear, which then allows the nuclear material to come out. Where are we at with blood pressure?
It's 130.
All right. So nowhere, basically. Are you comfortable? Shot. How bad did that get on a scale of 1 to 10? What was the highest it went?
5.
All right.
More pressure than pain.
Yeah. Well, you're not here for back pain, so we're here to fix your leg symptoms. All right. We can actually put him to sleep. He's got massive tears. The dye just went in so easy. Let me have a guide wire. Go lateral, get a lateral view. So most of our patients we do surgery on have really bad back pain or neck pain. All right, go ahead and count from 1 to 100. You can put them to sleep. Count out loud for me so I can hear every number.
1, 2, 3, 4,
Keep going.
5, 6, 7, 8, 9,
Shot.
10, 11, 12,
It's a little grainy. Shot.
14, 15, 16, 17,
Keep going. You're doing great.
19, 20,
Shot.
23,
Shot.
25,
Just lay still. Shot.
28, 29,
Shot.
30,
Shot. Keep going. Bring the table, can you bring the fluoro down to the ground a little bit? Table up a little bit, just a little bit. 1/4 inch, good. Shot. All right, so you can see our needles are in the L2-3 disc space right above the fusion. The disc is badly compromised. However, we're not here to make the disc back to its normal juiciness, height, whatever, integrity. What we're here to do is to unpinch the nerves that are getting pinched in the neuroforamen by doing a discectomy and to clean up the tear in the back of the disc that's allowing the nuclear material to escape and let it heal. So we're not going to heal for him, Sean. We can't heal an annular tear for anyone. How's he doing?
Well, he stopped breathing, so I have to go for him.
You need me to do anything?
Nope.
Shot. You want me to wait?
No, no. Keep going.
All right, so I don't know if you can see this, Sean, but there's dye in the other needle. You see that?
Yes, we do.
Right there. So I didn't inject this side right here, remember? I injected this side. But because both needles are in the same disc, the dye went from this needle through the disc, and it's coming out this side right over here. You guys see that? So obviously these needles are in the same disc, which is this is a good sign, by the way, but not unexpected. Should I wait or proceed?
You can proceed, sir.
All right. So we'll make our incision. The incision is going to be 7 millimeters long. The whole surgery is done through a 7 millimeter long skin incision, which is the smallest spinal surgery incision in the world. There's nothing smaller. Let me have the skin knife. This is a number 11 blade that I use. Now the areas that you get resistance are going to be the skin, which you're cutting, so you won't get resistance there. Next is going to be the lumbar fascia. Shot. You want to make sure your guide wire doesn't advance into the abdomen or pelvis. Shot. So I'm always looking at the front of the disc, making sure that it's not advancing. Now I know we're safe where we are. I can feel the herniation. Shot. So the tip of the dilator right now is in the neuroforamen. You all see that? It's in the back of the disc, but we're about 1.5 centimeters behind the disc. But I'm pushing against the herniation. I can feel it. So I have resistance now, and I'm going to actually push the herniation right back into the disc. Is he okay?
Yeah, I'm just putting a head strap on him to keep the mass in his face.
not a problem. Everything's going fine where I'm at. You have his pressure down, which is
Mercury is 105.
perfect.
That's why I couldn't drop it too fast.
It's okay. Shot. So again, I'm watching as I'm entering the disc space. I'm looking for the guide wire moving into the abdomen or pelvis. So I just do little advances at a time. Look at how it's spreading open the disc. You see that? Pretty cool, huh? All right, we are in the disc space with the tip of the dilator. I'm going to remove my guide wire. It's safe to do that. And now I'm going to advance this a little further. And I actually just shove the herniation into the disc space. Okay? So I'm going to go fetch it in a minute. So here, the whole surgery, folks, is done through this tube. This is a 7mm diameter endoscopic tubular retractor. It's a retractor because it retracts the tissues. It spreads them apart and holds them apart. So I can actually work through that tube. That goes over my dilator. The dilator will come out once I get the tube in position. The whole surgery is done through a 7mm skin incision and a 7mm tube. Now, if you're doing Metrix tubes or any of the other companies that do minimally invasive access ports, they're always about 18 to 25 millimeters. So we are 1/3 of the incision size. This is truly the most smallest minimally invasive spine surgery incision possible. How are we doing, guys?
Pretty good.
All right. Shot? All right, good. Well, our tubular retractor is in position. Shot. We're inside the disc. And we're going to remove the dilator. And we're going to get started with the real surgery. Let's pull that out for a minute. So up to this point, we call this exposure or access. And now we're going to start taking out what we came here to take out, which is the herniations. We're going to do it on both sides. I'm going to start with this side, patient's left. Oh, you want to do that? Any questions from our audience, Sean?
None so far.
All right, what you're watching, folks, is the most advanced spine surgery in the world to treat what are called symptomatic herniated discs. Symptomatic herniated discs. A herniated disc is found in the spine. Herniated discs cause symptoms like back pain. If they happen in the neck, neck pain. They cause radiculopathy or radicular symptoms such as leg pain, numbness, tingling, weakness, etc. Or in the arms, the same thing, numbness, tingling, weakness, or pain. Okay? So, herniated discs cause symptoms of pain in the back or neck, and then pain, numbness, tingling, weakness down the arm or leg. Take this. Don't give this to me yet. Come on. I need to first focus. Irrigation's on. Good. Why are we blurry? I think it's just stuff coming from the disc space. Okay. Let's see the grabber. We've already got a little bit of herniation coming out. We're going to put our pituitary rongeur in. How's the patient?
He's doing well so far.
Give me the... Going to bring the laser fiber down. The laser is really good for the annular debridement. The pituitary doesn't do the annular debridement. You need the laser for the annular debridement, which is 90% plus of what I do here. Cleaning up the annular tear. I am the first surgeon in the world to do it. We published this technique for annular debridement in 2012. It's in a journal called Surgical Neurology International. I chose that journal because it's extremely prestigious, but more importantly, it's free. Free to anyone who wants to gain access and read the articles. You see, for 100 years, new scientific discoveries that were published in journals that charged money to get a copy of the articles. So the only way you're ever going to learn anything new is by paying usually about $100 to $150 per article. So if you wanted to go to the library and do research and learn about new medical breakthroughs that are in medical journals, you literally have to pay money. Now, if you're at an institution of higher learning, such as a university, frequently universities would have accounts with those journals, and they would pay a large lump sum every month for their students and faculty to have access to those journal articles. But I found the whole process of having to break out your credit card every time you wanted to read something in the medical journals, I thought that was not such a good thing if you want to disperse knowledge and information about breakthroughs in medicine. So like other doctors and scientists, in this day and age, I chose a free journal, one that is open access. And I thought that it was important for people to have access to this technology and not have to pay money for it. So that's why we published, one of the reasons we published in Surgical Neurology International was to keep it available for the public free. But again, the technique of the Deuk Laser Disc Repair has been peer-reviewed and published. All of our equipment is FDA approved. There's nothing experimental about the surgery. Endoscopic spine surgery was done long before I started doing it. It was done in the United States, it was done in Europe, it was done in Asia, even before I started. What's unique about this surgery that I do is that my focus is on annular debridement along with herniation removal. Now what's sucking? Is that the bag?
Yeah,
All right. So I apologize that the picture's a little fuzzy. Every patient's different. We're not really seeing bleeding. What we're seeing is just a lot of debris and probably some of the dye that we put in, which is the indigo carmine dye. But I'm working on the annular tear right here. That's what I'm doing. This is a big calcified herniation right there. And what I found is that the grabbers are really good for removing chunks of disc herniation, but they're not good at all for doing the annular debridement. So the annular debridement, you really need a laser. And once again, you won't get the Deuk Laser Disc Repair procedure anywhere else but at Deuk Spine Institute here in Florida. There's a piece of herniated disc down there I'm trying to free up. The herniated disc material is always stuck to the annular tear. And what sticks it to the annular tear is chronic inflammation. So chronic inflammation produces collagen. Collagen is scar tissue. So the nuclear material, nucleus pulposus, that's stuck inside the annular tear gets scarred in from chronic inflammation. And that chronic inflammation once again produces collagen. Collagen is scar tissue, and it's scar tissue that holds the nuclear fragments in. So what I'm doing is I'm freeing these fragments of disc herniation up by releasing their attachments to the annular fibers. This will both allow me to remove the herniation, and at the same time I'm also debriding the annular tear. All right, so let's move closer to where the nerve root is. The nerve root is going to be to our left. Basically, the nerve root is at 9 o'clock, behind that metal tube. So the tube is retracting the nerve root, protecting this patient's nerve root from any damage by my instruments, including the laser. So the retractor, tubular retractor that I showed you, the metal straw, not just retracts tissue so I can do my job and see what I'm doing, but it also protects the nerves and other vital structures from being injured by me and my instruments. It's quite an ingenious system. Now, I didn't design this tubular system. Other surgeons before me did. There are not many endoscopic spine surgeons in the world. There's only a few. The reason for that is this technique is not taught during our training. It's really something that you have to learn after your training. So, for example, I went to one of the top neurosurgery training programs in the United States, if not the top, but they weren't doing this surgery there. They weren't doing it really anywhere, any neurosurgery training program. They weren't doing it in any orthopedic surgery training program. It was just a technique that a few spine surgeons knew in private practice, and I had to go to their private practices to learn. Standby laser. One of them was in Korea. It was actually more popular in Korea at the time that I was learning it. And there was a pioneer in Korea, Dr. Seng-Ho Lee, and he taught Dr. Gun Choi, and they taught me, along with a few other surgeons. And I also learned from Dr. Anthony Young in the United States. He was really the main endoscopic surgeon for lumbar, for lower back, which is what we're doing today. And he's retired now. He doesn't teach in the United States. He teaches in China. He's Chinese, so he travels to China and teaches over there. But there's really nobody in the United States teaching besides me right now. And I do it through the media that you're watching, through the internet, through social media, through Facebook, Twitter, Periscope, and other social media platforms like YouTube. So it's kind of a new era, and a lot of education has migrated to the internet, right? A lot of people go to online school nowadays. They do their because of COVID-19, they go to high school. They go to elementary school online. So it was universities primarily, but now a lot of education has migrated to digital format because of the virus, the COVID-19 virus. So I guess you can say, since we've been broadcasting my surgeries now for 6 years, 6 years, every single week that we do surgery, we've broadcasted my surgeries over the internet, live, unedited, for everyone to watch, free. We don't charge. Compliments of the Duke Spine Foundation for Research and Education. We've been doing online education for 6 years since we opened our doors. I see.
We have a couple questions.
All right, sure, I'll take the question.
Our first one comes from a viewer on YouTube who asks, do you ever do scoliosis surgery?
One of our viewers is asking, Dr. Deukmedjian, do you ever do scoliosis surgery? The answer is yes, I do. As a matter of fact, this surgery you're watching right now, this patient does have scoliosis, and they have it right where I'm operating. But the scoliosis itself is not the cause of their symptoms. So I'm not fusing their scoliosis, I'm not unrotating their spine. It's not necessary. What I've learned is that most people with scoliosis don't need fusions to fix their pain and their symptoms. They just need this surgery you're watching right now, the laser surgery. So this Deuk Laser Disc Repair surgery can fix pain and radicular symptoms from scoliosis. And that's really the main reason to do scoliosis surgery, is not to straighten your spine out, it's to get rid of the pain that comes with it. It's to get rid of the pinched nerves or radiculopathy that come with it, the spinal stenosis that comes with it. Nobody has surgery just because they have scoliosis. There are a lot of people with scoliosis in the world, and they have no pain, no symptoms at all. They're normal. They have completely normal lives. They have no symptoms whatsoever. They do not need surgery. So we don't do surgery because someone has scoliosis. We do surgery because someone has symptoms. I don't know a single surgeon in the world except for kids with idiopathic scoliosis that's really, really bad. There's nobody in the world that will do scoliosis surgery without symptoms. Patients have to have symptoms. So when you ask me, do I do scoliosis surgery? Absolutely. I can do the normal scoliosis surgeries, which are open with screws and rods and osteotomies to correct the deformity, or I can do it endoscopically like you're watching now. I fix literally thousands of patients with scoliosis that are symptomatic with this surgery. So you don't need to have a big fusion surgery to get rid of your scoliosis symptoms, okay? If somebody tells you that, get a second opinion. Unfortunately, there's a lot of misunderstandings and misinformation these days about treatment for things like scoliosis. People don't understand. Even the surgeons don't understand. Most surgeons don't do endoscopic spine surgery like this. Because they don't do this surgery, they're not going to give you that as an option. You understand? Surgeons are going to give you as an option the surgeries that they do. And if that surgeon isn't trained well, they're not going to give you the best options for treatment because they don't know them. They haven't been trained on them. Remember, I had to extend my training in spine surgery after I finished residency. After I finished my formal training, I had to go do mini fellowships in endoscopic spine surgery because I had a particular interest in it. But the number of surgeons that do that is less than 1%. So the vast majority of spine surgeons out there, and I mean spine surgeons, not just general surgeons, but the vast majority of spine surgeons don't go out and do endoscopic spine training, true endoscopic surgery training. Only a few of us do. So, but I do also scoliosis surgery, yes. I do screws and rods, no problem. And we do it outpatient. We do it in a way that no one else does. Normally with scoliosis surgery, you're going to stay in the hospital for up to a week or two recovering. But with Deuk Spine Institute, we can do your scoliosis surgery and send you home the same day. So it's much safer. You don't have to spend a week in the hospital. Who wants to spend a week in the hospital? Who wants to spend 2 weeks? Who wants to have complications? Nobody. So outpatient is much better. And on top of that, we've had 0 complications to date at the Deuk Spine Institute in 6 years of doing scoliosis surgery. So it's a much better option in my opinion. All right, so we're just finishing up on this side and I'm going to shift to the other side. But I just want to try to get as much of this herniation out as I can. Right now I'm just going underneath the nerve roots. The nerve roots are all medial to me at the 12 o'clock position. And I'm in the fibers of the posterior ligament right here. And this is part of the herniation and the posterior ligament right there. And I've removed as much as I can. But those white fibers right there are posterior longitudinal ligament. They're not necessary to keep them. And by releasing them, I can get further medial towards the midline to where some of this herniation still is. Just above those fibers will be some veins and fat, epidural fat. But this is all part of the herniation right here. Right here. You can tell it's been here a while because it's really inflamed and scarred in. All right, any other questions from our audience?
Yes, we do have another one. A viewer on Facebook, Jim, asks,
I couldn't hear you. I'm sorry, Sean. A little louder.
Can you hear me a little bit better now?
I think you need to turn your volume up on your mic just a little bit.
How's this?
Much better.
Okay.
Nice
One of our
and
viewers
loud.
is asking, is the herniated material you're removing made of calcium?
No, the herniated material I'm removing is not made of calcium, but it can become calcified. Okay, what that means is that when you have a process in the human body where you have an injury to tissues, that injury causes a reaction called inflammation. And over time, that's fat right there, by the way. That yellow stuff is just fat in the foramen. And it's just getting in my way. So, but anyway, to answer your question, hold this down here like this, please. Right here. Hold this. Yep, hold this right there. Don't move it. Over time, those damaged tissues will calcify with inflammation. So yes, they first scar and then they calcify. And that calcification process is known as dystrophic calcification. It's a calcification of tissue that's abnormal, shouldn't be there. And that scar tissue is always abnormal. It's a normal part of healing, but it's not normally there. Like if you have scarring in your liver, it's called cirrhosis. You're going to have microcalcification. Same thing with your kidneys. If you damage your kidneys, you're going to get interstitial nephritis, and you're going to get some calcification of those tissues. So if you look at that tissue with the microscope, laser off, you'll actually find calcium deposits. All right, so hold on. We're not done. All right, let me see the grabber. Let me see the laser. Those lights are too bright up here. Come on, guys. It's just underneath the root. All right, laser off. Nerve root is up there in the fat. I feel like we've gotten as much out as we can do safely. So we're in the foramen right now. Feel pretty good about it. We'll switch to the other side. Stand by. Scope is off, correct? So we're done with the left, and we're going to go over to the right side next. So we're going to deconstruct our equipment for a moment. Apply pressure here, please. And I'm going to switch sides to the other side. I'm going to switch over there, Sam, where you are. So we're not halfway done with the surgery, but we're halfway done with the part of the surgery where we're unpinching the nerve, so the discectomy and annular debridement. Watch it. Okay, great. So we'll go back to a lateral view, which we've already at. And I'm going to go ahead and place the guide wire on the patient's right side. It's funny, you can see the fluid coming out of the disc, right? With every breath. Okay. So look at that right there. You see that black thing? That's some dye in there. We got to get rid of it. So go AP. Just go up AP. Okay, and now drain the bag. That's good. That's good. Just drain the bag, get all that dye out of there, and now go back to a lateral. Okay? And let's see if that made it better. And shot. Yeah, that's better. All right, now I really need to see that disc space really good. So are you all the way to the bottom? Are you dropped? Okay. I guess that's pretty good. I wonder if we can do any better. Shot. I need to see that disc space a little better. You bring in something. I guess we lifted the bag again. There's still some liquid in there. All right, that's good. All right, I think we're good. I'm going to bring the needle out. Shot. Hopefully the guide wire is still where it needs to be, yes. So for those of you wondering, this surgery is not done where you are, whoever you are, unless you're in Korea or you're in one place in London or in England. There's only one endoscopic surgeon I know in England, Dr. King. And in the United States, there's probably only 2 or 3 of us in the whole country that can do this surgery. And the other doctors are not doing it, not because they don't want to do it. Of course they want to do it. They're not trained to do it. They don't have the training or experience or equipment to do it. So the reason why you don't see this available where you are is the same reason why you don't see, for example, a Rolex watch store. You know, they aren't everywhere. They're not in every single mall. They can't afford to be. It'd be too many stores. But this kind of stuff is only available in select places. Same thing why you don't find an NFL football game in every single city of the United States. There are just not, the opportunities aren't there for every single city to have an NFL stadium and football game. So you need the equipment, you need the players, you need the stadium. And the Deuk Laser Disc Repair is available at Deuk Spine Institute. And that's it. So it's like having an NFL league with only one stadium. And everybody has to go to that stadium to get the care. Shot. So unfortunately, that's not my wish, but when there are not many surgeons that know how to do the surgery, and it's only me, I can't be everywhere all the time. So as much as I'd like to be, I'm not omnipresent. And people ask, well, why isn't there a Deuk Spine Institute over here or over there? Well, great question. I wish there was, but I need more doctors willing to train on this technology, really is what it comes down to. For us to have more places in the United States where people can go get endoscopic spine surgery, you have to have more surgeons trained in endoscopic spine surgery. There is nowhere that's training them. In neurosurgery, there are 120 training programs, plus or minus, and none of them do endoscopic spine surgery. So how are the residents going to learn? Okay, if you're in a neurosurgery training program, you're going to learn how to clip an aneurysm or coil an aneurysm, maybe. You're going to learn how to take out a brain tumor. You're going to learn how to put a shunt in. You're going to learn how to do an anterior cervical discectomy and fusion, maybe a lumbar fusion, a microdiscectomy. You're going to learn hundreds of surgeries, but none of them are endoscopic spine surgery. I need the thingamajig. The thingamajig. Right? Very technical name. Shot. That looks pretty good. We're going to keep going a little bit more. So the problem is training. That's the biggest problem with this technology, is you can't go anywhere in the United States to get trained besides Melbourne, Florida. And truth is that most neurosurgeons don't want to go to Melbourne, Florida. Yes, we have beautiful beaches. Yes, we have a low cost of living. Yes, we have no state income tax. But we're not as hot and sexy as Los Angeles or New York or Atlanta. Shot? You know? We don't have that draw, that geographical draw. We got great people. We've got a great facility. Got great patients. Got the best equipment, the best supplies, the best of everything, but we don't have good quality spine surgeons that want to learn or want to move to Melbourne, Florida. Would it be any different if we were in Los Angeles or New York? Probably. Probably be a lot easier for me to recruit a surgeon to train them. But what you guys should start understanding is that, for me, I had to travel to learn how to do this technology. I was willing to sacrifice my own comfort. I was willing to not get paid for the time I was away learning. You know, I was doing it all because I believed in this technology. I didn't believe in it as much as I do today. Obviously, I believe in it a lot more today because I've treated over 1,000 patients with it successfully. And I know it's better than any other spine surgery because I do every other spine surgery. And I've done it, every other spine surgery. So I have all the other spine surgeries as a benchmark comparison, as I've done them in my career. All right.
We have another question.
Yep.
One of our viewers is wondering, how long is the recovery for this type of procedure, and what are the limits for this patient?
So the recovery is 1 hour. This patient's going to go home in an hour after their surgery. 1 hour. Okay? What are the limitations for the patient? Well, like every patient that has a spine surgery, they're going to have some restrictions that are going to last for a few weeks. Specifically with Deuk Laser Disc Repair, we have the least restrictions of any spine surgery. Okay? The restrictions are lifting. No lifting over 25 pounds for 6 weeks. 25-pound lifting restriction. And then they have to wear a back brace, a TLSO back brace. It's a special type of back brace. We give it to the patients. And that keeps them from bending at the waist. So no lifting, no bending. Let me have the laser. So really it's temporary restrictions. People can go back to work the next day. No problem. You can drive the next day. You can go back to work the next day. It's not like other spine surgeries where you're going to be laid up in bed or laid up in the hospital. Nobody wants to go to the hospital because of infection risk. And anybody in the world that's been recommended for a fusion can have this surgery you're watching instead. It's a more advanced technique than fusion. It's a much safer surgery than fusion. It's a faster recovery than a fusion. The reason why the visibility is so poor is that, remember, we already did the same disc on the other side. Okay? And I cannot fix both sides in the neuroforamen with a unilateral or one-sided approach. If I go on the right side, I can fix a pinched nerve in the right side, but I cannot fix a pinched nerve on the left side. So the reason we had to go on both sides is to try to unpinch the nerves on both sides. So I actually am getting the bleeding you're seeing here, this red color to the water, is from the surgery I've already done on the opposite side of this disc that we just finished. And it's affecting our view, okay? Now I can see what I'm doing. I've done this enough times. I feel comfortable doing it. But for those of you who've not watched many of these surgeries, it may be difficult for you to appreciate what I'm doing. But what I'm doing is I'm removing the herniation, which I've shoved into the disc from the foramen when I put the dilator in. and I'm also cleaning up the annular tear. The annular tear debridement is the key to the Deuk Laser Disc Repair surgery. If you don't debride the annular tear, the tear won't heal. If the tear doesn't heal, the patient can have a recurrent disc herniation. They can have another problem down the road. So no other surgery does an annular debridement but mine. I was the pioneer, the first one to do it, and the first one to publish it. So that's one of the reasons why there's such a high incidence of back problems after back surgery. How are we doing on irrigation? Because I'm not seeing a lot of flow, so I just want to make sure we're getting it. So the only reason I can do an annular debridement is because I'm inside the disc, seeing inside the disc. I can see the annular tear, and I can directly use the laser and directly visualizing the annular tear. Other surgeons don't have this view because they don't do inside the disc endoscopic surgery. They don't know how. They don't have the equipment to do it. But by being inside the disc, being inside the tear itself, like right here's the tear, if you don't have this view, you can't debride the tear. You can't fix the tear. Without fixing the tear, the patient's going to have another herniation, which is why so many people have back surgery. Maybe it works for a little while and then they get another problem again because the tear was not debrided properly. Did I answer the question, Sean? I know I went off on a tangent.
I'd say so. You answered it.
All good questions, by the way, from our audience. Sean, I kind of like when you say, we have this question from so-and-so on Facebook or whatever, Twitter. We need about 10 minutes, sir, and we'll be done. Doctor?
Yes, thank you.
10 minutes. How is our patient doing?
Blood pressure 102.
Good. But from a cardiopulmonary standpoint, good?
Yeah.
Good. Huh? That's why what?
I drop it in phases.
Oh, that's fine. Drop it in phases. I have no problem with that. Just make sure it's dropped when I walk in. when they
It did drop. I started at 156 over 103.
I believe you.
I got it down to 130.
No, I know that. I know that. I'm not saying you didn't drop it. I'm saying, try to drop it without propofol, first of all, but also try to have it ready to go when I walk in.
It was ready. 130
All
was
right.
a good pressure to start.
No. I like it around 110.
I'm putting it hypertensive. You need a higher mean pressure.
I understand. Trust me. I understand what you're saying. Well. Huh? Right. Why do you, let me ask you a question. I'm just having a discussion with my anesthesiologist. Why do you think I want his blood pressure low?
Well, I wonder because you don't have much bleeding there, but I also have to think about his perfusion of his brain and his
Of
bone.
course, that's not why I want the blood pressure low. Why do I want the blood pressure low?
Well, you tell me.
You tell me. I want to see what you think the reason is. Is it blood loss?
Obviously not.
No, of course not. We lose three mils, maybe. Well, is there somewhere I'm going that if you do have some blood loss in that space, that it could be a problem? Yes. I'm in the epidural space. And have you ever heard of an epidural hematoma?
I have to deal with that.
That's an emergency surgery.
I have to deal with that all the time when I'm doing
No, I don't deal with it. And the reason I don't is because I keep the blood pressure low. Even if you hit a vein, your blood pressure is not high. then your chance of developing a symptomatic hematoma is lower. You're not going to get as much bleeding.
The risk of the heart attack and stroke is higher.
I've never had that problem, ever.
So I'm trying to prevent it.
Yeah. Well, I understand. That's why I have an MD anesthesiologist who's good. Is because I don't want those kind of issues in my patients, right?
And you're doing a great job controlling the hemorrhage.
Of course.
So I'm not worried about epidural on your hands.
Well, the hemorrhage, what we're looking at is the disc. So we're inside the disc right now. So if you have an epidural hematoma, you won't see it inside the disc. This is not, there's no blood supply to the disc. The problem is when you go through the foramen, there are veins just there where you pass through into the disc, behind the disc, basically the epidural space behind the disc. That's what I'm most concerned about. You can see one of them there, a little vein right there. You see that? But the ones that I can't see are the ones I worry about. The ones that I can see, I can usually coagulate with the laser. It's the ones that are in the real epidural space I can't get to. Those are the ones that bleed. And then your patient wakes up and they can't move their legs and you wonder, oh shit, what happened? So, you know, part of the live stream is to allow our audience to be part of the conversations and action and what happens in the operating room, okay? The truth is that you're never going to hear these conversations anywhere else because they don't want you to hear it. Nobody wants you to hear it. Nobody wants you to see it. What happens in an operating room is like, you know, Area 52, right? Okay, it's highly guarded, highly protected. Normally, nobody talks about it. If something bad happens, it's top secret. It's all, you know, taken care of. So why do I bring you to the operating room and let you see what we do? Why? Because I'm so confident that we're doing better surgery than anyone else, and I'm so confident in our results, and we've had 0 complications, and I'm willing to show you that. I'm willing to put my money where my mouth is and show it to you, okay? That is a herniated disc right there. That's a piece of the herniation. Laser off. I've got to try to fish it out with the pituitary. I may not be able to get it, and it's kind of lateral, going to the side. So I got to open this. I may have to just keep whittling away with the laser. Yeah. It's not ready to come out yet. So I'll keep using the laser. But I'm a big believer in transparency in healthcare. Why? It's simple. There's this thing called informed consent. And I didn't create it or make it up. It was thought of by much smarter people than me. And informed consent is this principle that patients should have and be the ultimate decision makers in their health care. Either them or their surrogate, whoever they appoint to make those decisions. And I'm a big believer that everyone should know the truth, pros and cons, risks and potential benefits of every intervention we as doctors do. So, we show you these surgeries because of that. We show you these surgeries because I want people to know what they're getting themselves into. And also, I have confidence we have the very best surgery on the spine right here. challenge you to find better. You won't. How do I know? Because I do every other spine surgery in the world myself, and I've done them. And I've never found one that's better. Never. And I do them very well, by the way. Interesting. Yeah. So, if there was a better surgery out there, I'd be doing it. Standby laser. Instead of this. But I truly believe in this technology. Floor's a little wet. Why are we... okay. Well, that's medial at 12 o'clock is your epidural space. I'm going to laser. I'm going to remove a little bit more of this annular material. Now we're working right around his L2 and L3 nerve roots. So that's what was getting pinched. He has weakness in his legs, and my goal is to eliminate that weakness long term for him. Give him his ability to walk back to him. Now for those of you who've watched me do surgeries before, these types of surgeries, almost all of our patients have back pain. This patient doesn't have a lot of back pain. His symptoms are primarily weakness, and they're from the nerves being pinched really bad. So the problem with weakness is it can take up to 6 months or even a year to really go away. So unlike most of our patients that have immediate symptom relief right after surgery, this patient may or may not have to wait for those nerves to heal, the ones that were being pinched. Time will tell. I don't expect weakness to go away right away. I tell people that. I say it's going to take time for the nerves to heal from the injury, from being pinched for so long. Whereas back pain from the disc, that always goes away right away, like the day of surgery. So, but the pinched nerves take time to heal. They take the longest time. And the reason for that is they have to grow back. They literally have to grow back from where they are being pinched in the lower back or in the neck. They have to grow all the way down to the muscles that they're innervating, that are being deprived of innervation because the nerve has been compromised. Does that make sense? So I never tell people, stand by, let me have the grabber. I never tell people to expect the weakness to go away right away. And the truth is that I also tell them usually you have a 50-50 chance of the weakness, getting better or going away. The main reason to do the surgery is to keep you from getting weaker. Because a lot of times when people get weakness from a herniated disc or stenosis, that weakness is from a nerve damage, and it could be permanent nerve damage. And if it's permanent, obviously surgery, and no matter what we do, is not going to fix it. So when it comes to weakness, I tell people that expect a 50-50 chance of the weakness getting better, going away, But the real main purpose of the surgery is to keep you from getting worse. Which, if you don't treat weakness and treat the nerves, you are going to get worse for sure. That's a guarantee. Unless you have zero strength. If you're already paralyzed completely, then you won't get worse. There's a lot of bone spur there too. Hold this here again, like this. Hold this. Hold it. Yep. Thank you. Just a couple of more minutes. We should be done. If you have questions, feel free to ask them. Some of this stuff is just foraminal ligament. Let me see, I got it. If you're have any more questions for me, feel free to type them up, and I'll do my best to answer them for you. Sean, we have any more questions from our viewers?
Not currently.
All right. Well, what you're watching here today is bilateral L2-3 Deuk Laser Disc Repair. And the reason we're doing this surgery is we're trying to alleviate compression of the nerves at L2-3 in the lateral recess and neuroforamen of this patient who has developed adjacent segment disease from a spinal fusion he had 12 years ago by me. And about 1% of my patients who have spinal fusions go on to need a second surgery for adjacent segment disease. Now you may think 1% is a big number, but it's not. Most patients having spinal fusion end up, let me have a grabber, take the laser. And most other surgeons that do spinal fusions have about a 25 to 50% rate of needing to do another surgery. So it's actually more common than you think. Adjacent segment disease. It's the big thing that everybody worries about when it comes to doing fusion surgery. Nobody wants adjacent segment disease, but it's one of those things that are inevitable in some people that have spinal fusions, because what's happening is all that force is being transmitted to the next disc above the fusion or below the fusion. And whenever a disc has more force than it was meant to, because the other discs are not doing their job, of course, what's going to happen then is you're going to get those joints that are getting extra force put on them, more work put on them, they're going to end up wearing out faster. Joints do wear out, and discs are like any other joint. They can wear out quite easily, especially if they're injured. They wear out even faster. So just be aware of that. Laser off when you choose to have a fusion surgery. There's a nerve, and I don't see any more fragments of disc material. Looking pretty good. So we're done.
Lights on, please.
Again, this patient was a bilateral surgery because both legs are getting weak on him. So we wanted both of them treated. And when somebody has substantial symptoms in both legs, you have to do both sides. Okay, what's this here? All right, hold pressure. You want to show the audience the incisions? Move your hand. Sean, can you see?
Yes, we can see them.
7 millimeters, one on each side. Go ahead and put pressure. Thanks everybody, good job. I think we have another Deuk Laser Disc Repair next. Do they show up? We'll see. But I'm going to come to the conference room and answer questions. So if you have any questions, feel free to type them up. They don't have to be about Deuk Laser Disc Repair. It can be about any kind of spine problem that you or somebody else has, or any question you have about a spine issue, whether it's a surgery. Maybe you're thinking about getting a spine surgery. You have questions about it. What do I think about it? I'll be happy to share my opinions with you. But I'm going to call our EBO 3 mil. All right, go ahead and type those questions up and I'll be there shortly.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. And it was good.
No scars, didn't hurt at all. As you know, when I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to deukspine.com or call 1-800-FIX-MY-BACK for a free MRI review and consultation.
I feel like a new man again.
And it's thanks to Dr. Deuk. He gave me my life back.
Dr. Deuk did an amazing job fixing my back. I recommend him highly to anybody who has any kind of back issues, any kind of back pain. Don't wait. Go see him. The relief is amazing.
The pain level got to about an 8, a 9.
The right side of my body from the waist down was pretty much useless and in pain constantly.
The pain was chronic.
It was an aching, stabbing.
It became unbearable. It became where I didn't want to get out of bed. I didn't want to talk to anybody. I didn't want to do anything.
I had the pain every single day in my low back.
It's torturous. I can't go to sleep at night. I can't lay down. I can't sit for too long. Can't stand for too long.
I couldn't sit. I couldn't stand. I couldn't walk more than 50 feet.
It's excruciating.
Sends excruciating pain across my back. Gets down to my hands where my hands are numb.
I had no life.
If you are suffering from neck or back pain, the Deuk Spine Institute can give you the relief you need to live your life without pain.
Now I have absolutely no pain.
Not even 24 hours after the surgery was complete, I was able to be how I felt is normal. and it was good.
No scars, didn't hurt at all. When I woke up, it was totally painless.
The next morning, I was up and about and out, dressed on the job.
I have no pain. I'm living my life and doing great things, and I'm just very happy.
It's a great feeling not to be in pain.
Deuk Spine Institute has changed thousands of lives. Isn't it time you live your life pain-free? Log in to debridement.com.
Okay, Dr. Deukmedjian here, and we've just wrapped up a bilateral L2-3 Deuk Laser Disc Repair, endoscopic spine surgery using a laser. This patient came to us with a history of spinal fusion in the past 12 years ago, 2008, and apparently I did the fusion. It's lasted for 11 years, and he's developed a problem with the disc above the fusion, which is the L2-3. And he's got basically a presentation of leg weakness that's getting worse. He does have some back pain, but that's not the primary problem. He has some really weakness going in his legs when he's up walking and standing. We call that neurogenic claudication. And it really comes from the nerves being pinched where the holes are in the spine where they come out of. And they're being pinched by pressure being put on them from a herniated disc, and in this case most people have a herniated disc on one side or the other. This patient had it on both sides, and the herniated disc at L2-3 was on both sides. He also has a herniated disc above the level we treated today, but it's smaller, and I don't think it's causing symptoms. So we decided that we were going to do a bilateral L2-3 endoscopic Deuk Laser Disc Repair to remove the herniation and pressure on the nerves. Hopefully this will help his leg weakness. And as I said earlier, weakness and numbness take 6 months to a year to recover after spine surgery. And that doesn't matter what spine surgery you do. Once you've unpinched the nerve root that's being pinched by spinal stenosis from whatever's causing the spinal stenosis, most of the time it is a disc osteophyte complex. In most patients, it's basically a herniated disc in the back of the disc pushing on the nerve root. Once you get the pressure off the nerve root with surgery, it takes that nerve 6 months to a year to fully heal. And the reason for that is nerves grow back slowly, and they grow at 1.5 millimeters, almost 1.5 millimeters a day. And so 1 millimeter is just enough space between your fingers to see light. So 1 millimeter and 1.4 millimeters a day is really, if you measure with your fingers going from your lower back where the surgery is done all the way down to the part of your leg or arm that's numb or weak, you're talking about months for that nerve to heal. So I tell everybody that I do surgery on that has weakness or numbness, you got to wait for it to recover, for that nerve to recover. Now the back pain goes away right away that they have from the herniated disc. That's easy. Headaches, if you're talking about cervicogenic headaches from a herniated disc in the neck, that usually goes away right away. So the pain usually goes away right away. It's the numbness and the weakness that take time to recover. All right. Anyway, I guess we don't have any questions from our audience because they know everything there is to know about spine stuff. And we'll be signing off, and we'll be picking back up in 30 minutes with another Deuk Laser Disc Repair.